Good afternoon and welcome to today's presentation, the nuts and bolts of MIPS Advancing Care Information Measures. My name is Kalyn Henderson and I'll be your facilitator today. And at this time, all attending lines are muted to minimize background noise and distractions. We encourage your questions and input throughout this presentation, so please feel free to submit questions and comments in the chat box provided. At the end of today's presentation, we'll open the lines where you can use your raise hand icon in your taskbar and speak with today's presenter directly. Today's presentation will include interactive polling questions. In addition to our presenter has provided a copy of today's slide deck and useful resources, and you will find those noted handouts in your taskbar as well. Today's presentation is being recorded and later uploaded to our Health Vision Delmarva PTN YouTube channel. We welcome everyone to visit this channel simply by going to YouTube and searching Health Vision Delmarva PTN. You can also subscribe to this channel and even get post notifications as we upload more content, such as Part 1 and Part 2 of Nuts and Bolts MIPS in this three-part series. Today's presenter is Cindy Eisman, EMBA, Project Manager for Health Vision Delmarva. Cindy has over 30 years of experience in healthcare, starting in the area of health information and management and expanding her skills in areas of expertise to performance improvement, operations management, healthcare financing, and practice transformation. Cindy has been a CEO, COO, and Regional Quality Operations Director with Health South, Kindred, and several community hospitals. Cindy is a native of Pittsburgh, a graduate of the University of Pittsburgh and the Troy University in Alabama. Cindy, I'm going to transfer my presentation over to you.
Okay. So, good afternoon, everybody. Are we sharing?
You are sharing. You can go ahead and hit from beginning.
Screen. There we go. Okay, let me hide this. So I'm not looking at it, and we can get started. So welcome back to those of you who were with us for our first two sessions. We're going to cover the final session, the final scoring section for MIPS Performance Year 2017 today, and that is Advancing Care Information. So our objective today is to understand the ACI measures and to understand how they're scored and how they impact your total MIPS score. Not so much about selecting which measures are appropriate for you this week because they're pretty much set measures. Our agenda is we're going to do, again, a brief overview of the components and eligibility just as a refresher and for those who weren't with us the last 2 weeks. Then we're going to talk about the MIPS ACI measures and how we're going to submit our MIPS ACI measure data. Our questions to run on this week. So the things that you want to be thinking about as I go through this presentation. First, how does the ACI reporting differ from meaningful use? Because it does. There's similarities, but there are also differences. How can I use my EHR technology to meet these requirements and improve my practice operations? And how can ACI scoring improve my overall MIPS score? So what is MIPS? For a brief overview, as you remember, MIPS is the new value-based payment program from Medicare. It streamlines 3 Medicare legacy programs, PQRS, Meaningful Use, and the Value-Based Modifier program into one program. And then it adds that 4th component of performance improvement and innovation activities. It allows clinicians some flexibility to choose measures and activities that are more meaningful to their practice. In 2017, although there are 4 categories overall, the MIPS, only 3 of them will be scored. It will be calculated this year, for this performance year, based on just your quality, improvement activities, and advancing care information scores. And then the cost category will be added back in 2018. Because we have 3 categories, they have to be weighted so we know how much each of them is worth. And so the weights for 2017 are 60% for your quality measures, 15% for your improvement activities, and 25% for your advancing care information. These are default weights, and they could be adjusted in certain circumstances, and we're going to talk about one of those circumstances today involving ACI. Because it's a new program and we want to make sure that everyone is able to participate and get on board, CMS did roll out what they call the Pick Your Pace participation in 2017. We have 3 options. We have the test pace, For the test pace, literally means submit something, anything, one measure, whatever you can. And it's just one measure in one of the three categories of ACI improvement activities or quality measures. This will guarantee that you do not get a negative adjustment to your fee schedule in 2019. If you're not quite ready, if it's going to take you some time to be ready to submit what you feel is solid data in 2017, if you at least report for 90 days, so that would equate to the final quarter of the year. If you report data from that one quarter, that would be a partial year, and that would allow you to be eligible for a small positive payment adjustment, or the option of full year participation. If you've already been participating in PQRS and in meaningful use, the full year option is probably the one that's right for you. This is submitting a full year's worth of data. You would get a modest, positive payment adjustment based on your performance. This is very important. Non-participation in QPP, if you do nothing at all, will result in a negative 4% payment adjustment to your fee schedule in 2019. So you really do want to take advantage of whichever pace, test, partial year, or full year, best meets your practice so that you can avoid that 4% negative adjustment. This is just a little more on test your pace. It does mean just submitting a minimum amount of data, either one quality measure or one improvement activity, or if you're going to do it with your ACI measures, you have to do all of the base measures. You have to submit data on all the base measures, and we're going to talk about that today. As far as partial and full year reporting goes, you can submit measures anywhere from a period of 90 to 365 days. The best way to earn the largest positive payment is to submit data in all categories, some data in all categories. And positive payment adjustments are based on performance rates, not the amount of information submitted or the length of reporting. So even if you can't, you're working with your EHR and maybe there's some changes you need to make, or your reporting, needs to be tweaked, or your documentation so that you get good data and you can only get 90 days in, that's okay. If you do really well, your increase is going to be based on your performance, not on the amount of data that was submitted. Practices also have to select individual or group reporting, and whatever they pick, they have to do it the same for all the MIPS categories. So if you pick group reporting for ACI, you have to do group reporting for quality measures and group reporting for your improvement activities. If you select individual reporting, you have to do that for all the categories. If a practice is an ACO, you must do group reporting in an ACO. It does not matter how you bill. Just because you bill as a group, that doesn't mean that you can't submit individual data. The way you submit data is based on two things tied together, your NPI number and your TIN. So you can put the whole group together, or you can just submit each individual using the TIN and the NPI number. So to review what we've done in the last 2 weeks already, the first week we talked about quality scores. And the quality score, worth 60% of your score in the first year, is calculated by adding up all the points that you earn on the 6 quality measures that you select, add that with any bonus points, and divide it by the maximum number of points that you are eligible for. That's going to give you a score on a base of 100. The other thing we talked about last week was improvement activities. So this is how improvement activities were going to be scored. You're going to look at the points earned on your improvement activities, and you're going to divide that by a maximum of 40 points to get, again, a score based on a base of 100. That will be worth 15%. So now we're ready for our first polling question. Kalyn, if you'd like to launch that.
Our first polling question is, have you attested to meaningful use in the past? Your options are yes, we've successfully reported and haven't been penalized, Yes, we reported but still had penalties, or no, we have not reported meaningful use. Just give it another second to get everyone to participate in this poll. We have about 70% voted. All right, I'm going to go ahead and close that poll. And I'll share. Cindy, we had 86% said yes, we have successfully reported and haven't been penalized. 8% had reported but still had penalties, and 5% had not reported.
Okay. So that's a pretty good percentage of people who have already been successful with meaningful use. And I think that a positive then coming out with this new system of ACI this year is going to be, I think that you will find that you will also do well within the system. There's a little more flexibility and there's partial credit. So that might also help those of you who reported but still experienced a penalty because you didn't hit the benchmarks that you needed to. So there's the potential for partial credit. And then we'll talk about people who haven't attested and the potential for not exemption or exclusion, but something called reweighting under this system. So now to the meat of our presentation today, advancing care information. ACI is worth 25% of your MIPS score in 2017. It does replace meaningful use. The following categories of practitioners have this as an optional. They don't have to report it. So if you are a nurse practitioner, billing on your own. If you are a physician assistant, billing on your own. Clinical nurse specialist, certified registered nurse anesthetist, non-patient facing clinicians. We talked about those last week. Those are people who are not actually working directly with patients. I always give the example of a pathologist working in a lab. And then hospital-based MIPS clinicians. So these are clinicians where 75% of their Medicare work, Medicare payments, are performed on the inpatient side in the ER or in an on-campus outpatient department. So if you are an infection control physician and you only practice, basically 80% of the patients you see are in consultation in the hospital, they're inpatient consultations, you would not have to report ACI. If you work you're an emergency room doctor, you don't have to independently report ACI. It's optional for you. However, if you do report data, the measures will be scored. So, you have to look at whether you fit one of these categories to be optionally exempted, and then do you want to submit the score. If you elect not, if you are an optional, in the optional category, and you elect not to submit data, CMS is going to reweight the 25% that would normally be assigned to this category to the quality category, and your quality measures would be worth 85%. So this is an important thing to understand and know. Also for practices where you have one practice, you're billing under one TIN, one group, and you have nurse practitioners who have their own NPI. And even if they are billing incident to the physician and you're not billing under their separate NPI, you don't have to submit data based on their NPI numbers. So you definitely want to pay attention to this and make that decision. Do you qualify under the optional category, and then do you want to or not want to submit data? Remember, if you don't submit data, it's going to increase the weight of your quality measures. So this is the other reweighting option. Some of you, we have 5% who haven't attested to meaningful use. Some of you may have in the past applied for an exemption from meaningful use. And if you did, you know that process. There's an application that you have to fill out. They ask you a bunch of questions. You have to make the case for why you are unable to have a certified EHR. MIPS clinicians have to use a certified EHR to be able to report ACI. So if you don't have one, then you have to meet this criteria in order to qualify for a reweighting of this category to 0%. Simply lacking a certified EHR is not sufficient to qualify for a reweighting in this category. Just not having an EHR doesn't qualify you. In order to qualify to have the 25% reweighted to your quality bucket, you would have to show one of the following: that there is insufficient internet connectivity in your location, that there were extreme and uncontrollable circumstances that prevented you from complying, or there was a lack of control over the availability of a certified electronic health record. I will say that this is a pretty high bar to hit if it's being interpreted literally. I also know of practices that have successfully applied for and received exemption for numerous years. So if you don't have a certified EHR and there is just no way that you can get one, I would strongly recommend you keep your ears open. We will let you know when these applications for reweighting become available, when the process is opened, and can direct you to that. I would strongly recommend you make the effort to make the case for why you are unable to have a certified EHR. If you are awarded reweighting, you put in the application and you are reweighted, they will reweight the 25% from this category to the quality performance category, and that does mean that your quality measures will count for 85%. So it ups the pressure on making sure that you're doing well on your quality measures, because it's really going to account for the largest part of your MIPS score. Again, more information about this will be available in 2017. And so I would imagine we will have questions on this. I do want to hold questions to the end, but if you want to type in the chat box, Kalyn will be happy to pass those along at the end when we get to questions and answers. So how's ACI scored? You take a base score. There's 4 or 5 base measures. We're going to add performance measure scores to that and bonus points to end up with a possibility of 155 points. However, the score is actually capped at 100. So you have a lot of opportunity here and a lot of different ways to reach 100 points. There's actually 155 possible, and you only have to hit 100 to get full credit for the category. And if you get full credit for the category, that's going to add 25 points to your MIPS score. So we'll go through how it's done. This is just a little recap of what it means to do the test pace using your ACI measures. If you want to only test the system, but you want to do it using your ACI measures, you do have to submit all base score measures. So unlike a quality measure, if you want to test the system using one quality measure, all you have to do is pick one measure and submit data from one patient. But if you want to use your ACI score to test the system, you do have to submit information on all 4 or 5 of the base scores. The full list of measures is again available at the qpp.cms.gov site, which I probably shouldn't have just clicked on. There it goes anyway. Sorry about that. Because I have it pulled up here. Remember the site, it's qpp.cms.gov. Once you go to Explore Measures at the top, you get these 4 to pick from, and if you just pick Advancing Care Information, it takes you right to this page, and you can do the same thing that we went through last week. You can read about each of the measures, you can download them to a list for future reference, and you can get the information that you need about using those measures. So let's talk about certified EHRs. You do have to use certified EHR technology in order to successfully report ACI measures. You can use a 2014 edition of a certified EHR, a 2015 edition, or some combination thereof. In other words, if your EHR is upgraded during the reporting period, you might have part of the year in 2014 and part of the year in 2015. Everyone does have to upgrade to a 2015 EHR prior to next January. So this is the last year that you can use 2014 editions. At some point during this year, if you're not already upgraded to 2015, you're going to be upgraded to 2015 if your EHR intends to remain certified. Talk to your EHR vendor. You need to know what edition you are so that you know what you're working with. So there are 2 measure sets depending on what edition you're using. There's a measure set called the 2017 Transition Measures, and these measures are for people who are still on the 2014 edition using a combination of 2014 and 2015, or frankly, the 2015 edition users could also be using transition measures. However, the sort of permanent, if you will, ACI measures, the ones that will be in place going forward, those can be used if you have a 2015 edition or a combination edition. So really, you only kind of have to use the transition measures if your EHR is a 2014 edition EHR. If you're using 2015 or a combination, you can move on to the new measure set. So Kalyn, you want to put up the next polling question?
Absolutely. The next polling question is, what edition EHR are you using? 2014, 2015, a combination of 2014 and 15, or I do not know what edition my EHR is? I'll give it another second. We ask everyone just take a second and participate in the poll. We have about 58% voted right now.
Now this is sort of an easy question, so.
I know, so I'm trying to encourage some feedback. We're only 70% right now. Alrighty, I don't want to keep it open too long and take away from your time. We are at 70%, Cindy, so it's not everyone, but here is a good chunk of everyone. We have 31% said they had a 2014, 21% said 2015, 3% was a combination, and actually 46% did not know what edition they had.
And that's what I was thinking when it wasn't being answered so quickly. So, you know, I'll go back and say, guys, talk to your EHR vendor. You need to know what edition your EHR is. It's going to be very hard to make decisions and know that you're completing things correctly, using your EHR meaningfully, if you will, if you don't know which measure set you're using. Okay. So we're going to look at both the transition measure set and we're going to look at what I would like to call permanent ACI measure set. This is the transition measure. So this measure set could be selected if your EHR is 2014, 2015, or a combination. It's the one you have to use if you are a 2014 edition. There's no other choice for you. So you can see that there are base measures and then there's performance score measures. The 4 in the blue are your base measures. You have to report these in order to get any points in this category. And not only do you have to report these 4, this first one, the security risk analysis, you have to say yes. If you don't perform a security risk analysis of your EHR and your processes around your EHR, you cannot get points at all in the ACI category. It is a mandatory item, a mandatory measure. So the security risk analysis is the first one. We'll talk a little bit more of definitions later. It is required for the base score. It's a yes or no attestation, but yes is required if you want to get any points. It is not selectable for a performance score, so you would never use this for a performance score. E-prescribing is the next base measure. It is required for the base score. It is reported as a numerator and a denominator, but for the base score, the requirement is that you have to just report 1 in the numerator. So you have to have basically e-prescribed for 1 patient. So you don't have to have there's no benchmark to hit. You have to have e-prescribed for 1 patient. This is also not selectable for performance scoring. So these first 2 only count for base scores, and they are required. The third one that's required is patient access. It is required for the base score. It is also reported as a numerator and denominator. Again, 1 patient needs to have accessed basically your portal to get credit here. Now, this one is also eligible for performance score points. And it's worth 20%. The potential value is 20%. And you report a numerator and denominator. So yes, you only have to report a numerator of 1. So 1 patient out of 1,000 accessed your portal. That gives you the point for your base score. But it's not going to give you really anything in your performance score. But if 100 people out of 1,000 accessed your portal, you could get, it would be worth basically 10%, 10 points, if you will, 10 performance points that are weighted at 20% of the total performance point score. So the better you do in your performance, you'll be eligible for points. And we'll look at a table that explains that in a minute. Health information exchange also is a required item for the base score. It also is reported as a numerator and denominator, but the numerator only has to be 1 for the base score. Again, it can be used for performance scoring, and the better you do, the more performance points you'll get. So those are the 4 in the transition measures that are required for your base score. If you want more points, if you want performance points, then you would report numerators and denominators not only for these base ones, but also for these activities: view, download, and transmit, patient-specific education, secure messaging, medication reconciliation, and the use of an immunization registry. These 4, VDT, education, secure messaging, and reconciliation, are all numerators and denominators. Immunization registry is a simple yes or no score. We'll talk more about the definitions of these in a minute. But that's the transition measure set. This is the set that would have to be used if you're using a 2014 EHR. It can be used if you're using a combination or a 2015 EHR. So now moving on to what would be sort of the permanent ACI measures going forward. You cannot use this set if you use a 2014 edition EHR. It's only available to people using a combination or a 2015 EHR. You have 5 base scores because basically they split up health information exchange into 2 different activities. It's pretty much the difference. You still have to do a security risk analysis. You still have to answer yes to get any points. You still have to do e-prescribing. Same thing with the numerator and denominator, with a numerator of at least 1, and there are no performance points available for e-prescribing. Same thing for patient access as in the other set. Yes, it's in the base score, numerator and denominator with the numerator greater than or equal to 1, and also potential bonus points. Health information exchange has been divided into sending a summary of care to another provider or requesting/accepting receiving a summary of the care from another provider. These are in the base score. Again, just to get the base score, you only have to do it once, but it's available for performance scoring, and the better you do, the more points you get. You can see that the remaining performance scores are very similar to the other data set: VDT, education, secure messaging, but we have patient-generated health data added, clinical information reconciliation added, and the immunization registry also continues to apply and still requires a yes or a no. So again, this set can only be used if you're at least using a 2015 edition EHR or a combination 14-15 EHR. So now the next 2 slides get kind of busy, and we're not really going to go through all of this in detail, but the detail is there, and one of the handouts that was in the handout box is a separate spreadsheet, if you will, with these definitions. I wanted to share these with you so that you see and have handy an easy reference for the definitions of these measures and what they mean. Your EHR vendors will be knowledgeable in these measures, and it's important to understand from them and sit with them and go through each one to understand which fields need filled in for you to get credit, how the score is actually calculated, how they pull the data for reporting to allow you to attest to both attest and report your numerators and denominators. So this does describe, what is the security risk analysis. If you have done meaningful use, you know what that is. It's really important that you do it and do it correctly. There are ways that you can do the security risk analysis yourself. There is actually a link at CMS that will take you to sort of a self-assessment to be done. I have been cautioned by people who have done this in the past, people at CMS, as well as people who have assisted through the Quinn QIO, that the audit rate for people who self-assess is a little bit higher, and the failure rate on audits is a little bit higher. So if you're going to self-assess, self-analysis yourself, you do need to make sure that you truly understand, how you're answering those questions and the information that you need to support the answers that you give on your assessment, and just in case you're audited. I mean, in the long run, you're going to attest, you're going to say yes or no, you did it or didn't. It's more a matter of having the backup documentation to show that you adequately assess the security, not only of your EHR, but of the processes that surround the use of your EHR. E-prescribing, at least one permissible prescription written by the clinician is queried for a drug formulary and transmitted electronically using the technology. So to get the base score, it needs to happen at least once. The more times you do it, the better you're going to, excuse me, I'm going to take that back. That's not a performance score, so you have to do it at least once. Patient access. Now we start getting into the ones that you can also get performance points on. What does patient access mean? At least one patient during the performance period is provided timely access to view online, download, and transmit to a third party their health information, subject to the MIPS clinician's discretion to withhold certain information. So patient access electronically to their data. Just one patient doing it gets you the base score point. If you want to accrue more points, the more people that do it, the higher your score. Health information exchange means that the clinician that transfers or refers a patient to another setting of care uses the EHR technology to create a summary of care and electronically submit that summary to another health clinician. Again, just for one patient, that gets you the base score. The more you do it, the higher your performance score. What is VDT? At least one patient seen by the clinician during the period views, downloads, or transmits their health information to a third party themselves. The more that happens, the higher your score. So your use of your portal is really coming in strong here, as you can see. Patient-specific education. The clinician uses clinically relevant information from the EHR to identify educational needs and provide access to those materials electronically. Again, at least one patient, but the more you do, the higher the score. Secure messaging. For at least one patient, a secure message is sent using electronic messaging function of the EHR. Medication reconciliation. The clinician performs medication reconciliation for at least one transition of care when the patient is transitioned to another eligible clinician. And then immunization registry. The clinician is actively engaged with the public health agency to submit immunization data. So those are the descriptions and definitions of what each of these things are. These are the only scoring items for ACI. There's a couple of bonus points available, and we'll talk about those, but there are no longer ECQMs. So something that's been clear to us as we've been working with practices is there seems to be a lot of confusion about whether you were submitting PQRS quality data or whether you were submitting ECQM quality data through your meaningful use submission. And they're really they can be two very different things. There is no requirement anymore through ACI to submit quality data measures. All quality data is going to be submitted through the quality reporting bucket of MIPS. Now, your EHR may submit that data for you, and we talked about the different submission methods for quality data in our first module. So your EHR could be the avenue by which you report it, but we're no longer reporting it as part of meaningful use. We will be reporting it as part of the quality bucket in MIPS. These are the definitions for the 2017 measures, the ones that will be permanent going forward. They're very similar. We're not going to go through them to take up that time, but it's available for you to review. The same information is also available at qpp.cms.gov. Okay, so we talked about what the measures were. We know what they are. We know which ones fall into the category of base measures, and we know which ones fall into the category of performance measures. Now, how do we score it? MIPS eligible clinicians have to fulfill the requirements of all the base score measures in order to get the base score, and the base score is 50% or 50 points. In order to receive that 50 points, the eligible clinician must submit a yes for security risk analysis. There's no other, you can't say no to security risk analysis. If you can't say yes to that, you stop right there because you can't get any points in this category. You also have to submit at least one in the numerator for the numerator-denominator of the remaining base measures. So that will get you a 50% of the score required here. If these first two listed requirements are not met, you will not receive the 50% base score, and you will get a 0 in the overall advancing care information performance category. So you have to get the base score before you can get any performance points. And in addition, some of the base score measures can also contribute towards your performance score, and we showed which ones those were in the previous slide. So your base score is worth 50% or 50 points. We've gotten past that. We submitted one in every numerator, and we could say yes to our security risk assessment. How do we do performance? The performance score is calculated using the numerators and denominators submitted for the measures included in the performance score section, or for one measure by the yes or no submitted, which is the immunization measure. The potential total performance score is 90%. So you can get 90% or 90 points out of the performance category. For each measure with a numerator denominator, the percentage score is determined by the performance rate. So how well you do determines your score for each one. Most measures are worth a maximum of 10 percentage points, except for two, patient access and health information exchange, which are worth 20 percentage points. And those only fall in the transition measures bucket. The only performance score measure that's yes or no is immunization registry reporting. If you're actively engaged with a public health registry, you simply have to attest yes, and you would get the full 10% for 10 points. This is the table that tells you how many points you would get. So when I gave the example before, for example, of let's say patient portal use, right? If you had a performance rate of 50% of your patients use the portal, you would get 5 points out of a possible 10 for that measure, because that measure is worth 10. Each measure, that measure is worth 10 points, so you would get 5 points of it per half. This table tells you, based on your numerator divided by your denominator and the percentage that gives you, how many points you'll get for that measure. For the two measures that are worth 20 points, this is the way it goes. So if your measure is worth 20 points and 50% is your performance, you'd get 10% or 10 points towards the performance, that performance measure in your ACI. I said to my staff as I was preparing for this week that this particular section, I was glad I did this one last because it almost gives me a headache. There's a lot of moving parts to it. There's a lot of percentages being thrown around. When we go through the scoring example, I hope that it makes it a little clearer. And I also suggest that you keep these handy to refer to, these slides, because it will help you go back and kind of plot out your score. Another one of the handouts in the handout box is actually the qpp.cms.com handout, or .gov handout on this scoring. And it actually also is relatively clearly written and has a lot of these tables in it. So I just want to direct you back to those. Okay. So we have our 50% points for our base score. We add up all our numerators and denominator points and come up with a performance score. And then we have an opportunity for some other additional bonus points. You can get 5 points for any one of the following: participating in a clinical data registry, in a specialized registry, in a public health registry other than immunization, a syndromic surveillance registry, or doing electronic case reporting. You can get 10, and all of those are described and explained in that handout that I talked about that's in the handout section. You can get 10 points for utilizing certified electronic health record technology to complete one of the 19 improvement activities. That's a bonus activity. And we actually talked about those last week when we talked about improvement activities. This is a slide with those again. These are the 19 improvement activities that if you select and do one of these as your improvement activity, you also get 10 extra bonus points in this category. So if you'll use your certified electronic health record to help you provide 24/7 access to clinicians or groups in real time. So if, for example, your on-call physician can access remotely your patient's EHRs, so they can meaningfully interact with the patient, you get 10 extra points in this category, and you get high-weighted points in the improvement activities category. So that's why last week we told you, think about these ones or these activities that you could and should and want to do, and can you use your EHR to help you do them. So here's the example of how we calculate. And you can see this one is way busier than the previous weeks when we looked at previous slides on how we calculate a score. We're going to use our same practice that we've been building on. So we have a 3-clinician practice who reports as a group. And our group does use a certified EHR in the 2014 edition. And so they're going to report as follows. They are going to report their security risk analysis, and this is how they're reporting, and they can say yes, they did their security risk analysis. So that did satisfy the requirement for the base score for that measure. E-prescribing. Yes, it's required. They report that they did that 700 out of 1,000 times, so yes, they more than did enough because they did 700 out of 1,000 times. Yes, it satisfies their base score requirement. For patient access, they report 600 out of 1,000, and yes, because they at least reported 1, that satisfies their base score. Health information exchange, they report 750 out of 1,000. Again, they at least reported 1, so they report yes, and that means they did all the things they needed for their base score, and so their base score does come out at 50, they get the 50% points that they needed for their base score. Okay. Now, what about their performance score? Well, the first 2 that they can use for performance are patient access and health information exchange. So remember, for patient access, they reported 600 out of 1,000, or 60%. And so if we go back, darn it, and look at our table, and there it's worth 20% there, and they did 60%, they get 12. That's their score, 12. 60% gives them 12 points for that measure. So you see why you have to refer back to that table all the time. For health information exchange, remember they reported 750 out of 1,000, that's 75%. When I go back to my table, it tells me that's worth 16 for the score. They also reported all of the other performance measures. So they got 50 out of 100, or 50%, giving them 5 points for that measure. Patient-specific education, they got a 90%, giving them 9 points, and so on. You just look at every single one, take the numerator divided by the denominator, make it into a performance rate, and then go back to your table and find out how many points that's worth. We do that for every one of these. And when we're done, we add it up, and our performance score is 66%. So we're going to add the 66% to the 50% plus any bonus points. Our group also does one IA activity that carries ACI bonus points. They provide 24/7 access. That earns them 10 bonus points. So they have 50 base score, 66 performance, 10 bonus. 50 base score, 66 performance, 10 bonus. They get 100 points. Now you're going to say to me, no they don't, they get 126 points. Actually, even though 50 plus 66 plus 10 adds up to 126, the ACI score is capped at 100. So anything over 100 is awarded a final score of 100. They end up with a 100-point score. If I take that and add that to our table that we've been working on, remember our quality score, we ended up with 57 points for quality, 15 points for improvement activities. We take our 100 advancing care information points that we just calculated, multiply it by the weight of 25% for this category. That gives us 25 points, and we add the 3 together. This practice got a 97 out of 100 score on their MIPS for this year. So we've calculated points for each category. We've multiplied them by the weight for the category, added up those sums, and come up with the total points for this practice. Just to be clear, or at least to try to be, here's another example of scoring. So looking back at this table. Let's say our group used certified EHR but only reported the minimum amount of data required. So that would mean they reported what was required for the 4 base measures. They said yes to the risk security analysis. They reported at least 1 e-prescribing, 1 patient access, and 1 health information exchange event. They did satisfy the base score. That gives them their 50% base score. Because they didn't report anything more than 1 or any other performance data, they get no performance score points. Let's say our group still does that one IA activity that carries ACI points, providing that 24/7 access to the patient's records for the clinician on call. That earns them 10 points. And they also participate in a specialized data registry, and that earns them 5 points. Their score would look like this. They got the base score of 50. They didn't submit anything to get a performance score, so they got no performance score points. And they got 15 bonus points, 1 for their improvement activity that used the EHR and 1 for the specialized registry. That gives them 65 score. Because the actual total is 65, that becomes their score. So your ACI score ends up always being the lesser of this total or 100. Most you can score is 100, but if you don't get to 100, then you actually get the score that you added up to. If that was what if they had scored 65 and we multiply 65 by the 25% weight, our same practice would have scored an 88 instead of a 97 for their final MIPS score using that example. So how are you going to submit this? Well, you can. There are different submission methods, just as the other ones with group or individual. You do not, and I'll correct something from last week, you do not have to submit all of your measures in all measure categories the same way. You just have to submit all your measures within a category the same way. So if you're going to submit your quality measures through a registry, then you submit all of your quality measures through a registry. But you can then attest to your improvement activities using the CMS website, and you can attest and submit your EHR information through your actual EHR. So you just have to pick 1 for each type of measure. And these are the different ways that you can submit and attest to your ACI information. And a word on group reporting. When reporting as a group to the Advancing Care Information Performance category, the group would combine their MIPS-eligible clinicians' performance under 1 taxpayer ID number. Therefore, they're not calculated based on a MIPS-eligible clinician's performance. So it doesn't stand alone. So you're going to do it under 1 TIN. It's going to be reported as a group. If reporting as a group, a hospital-based MIPS clinician don't need to be included in the group calculation. So if you have both hospital-based and practice-based clinicians, you don't have to include information on your hospital-based clinician in your ACI performance categories. And then finally, detailed guidance regarding this is going to be provided in future sub-regulatory guidance. So there's still a little bit to clean up on this. Remember, you're not reporting anything until the first quarter of next year, so we have some time to work that through and get that additional information out to you. So in summary, all ACI reporting has to be completed using a certified EHR. Clinicians have to attest to having completed that security risk assessment to receive any points at all in this category. Clinicians have to report data for at least 1 patient, that is numerator equals 1, for all the remaining base measures to receive any points in the category. Some base measures also allow clinicians to earn performance points on actual performance over and above that minimum numerator equals 1. Additional performance measures over and above the base measures also allow for more points to be scored in the performance category. Bonus points are available both for certain registry reporting or completing a ACI-related improvement activity. And 2014 editions of certified EHRs are valid in 2017, but you have to move to 2015 by the end of this year to continue to be using a certified record. So we'll have our final polling question, and then we'll have questions and answers, if you'd like to launch that, Kalyn.
Yes. After this webinar series on MIPS scoring, you have three options. I feel confident that I can select and track my measures. I feel more confident but not completely confident. Or I still have many questions and could use more help. We have about 40% voted. I'll give it a little bit longer. Give it 10 more seconds. See if we can get over 70% of participation today, Cindy.
Okay.
Ah, we broke 70%. Okay, I'm going to go ahead and close this. I'll share the results with everyone. We had 41% said that they feel confident that they can start tracking their measures. 46% said they feel more comfortable but not completely confident. And 13% said they still have many questions and could use more help.
Okay, well, that actually came out better than I thought. So the good news is we're still around and available to help you, and this is a category that we're going to see a lot more detail come out on. I will also say that as frustrated as we sometimes get with our EHRs, this is going to be the one category that your vendor will know the most about and will be able to probably help you with a bit more. So, you know, I think that we'll be okay with it, and we're just going to keep working on it through this year as the additional information comes out. I wanted to point out a couple things, and then we'll go questions because I run out of time every week. We do have the link to the YouTube site, and there are some good related videos out there that I strongly recommend. If you haven't watched these, you go out, you know, get yourself a sandwich, sit down at lunchtime one day, and listen to those webinars. Quality Insights did help us a lot with the content for this presentation, so we do want to give a shout out to them. And we again give you the link for qpp.cms.gov, and then I'll just leave up on the screen our contact information, but that's also the last slide. So, Kalyn, do we have any questions?
Yes. I want to remind everyone, if you want to speak directly to Cindy live, you're more than welcome to use the raise hand icon in your taskbar. Cindy, we do have a couple questions I'm going to just read off to you to start off with.
Okay.
The first one is, our current EHR is the 2014 edition. They've informed us they will be upgrading to the 2016 edition shortly. Once we upgrade, how would this affect how we choose which ACI measure to report on?
Okay, so because you're going to basically end up with a combination this year, right? Part of the year you'll be 2014 and part of the year will be 2015. You can select either measure set. Whichever one appeals most to you is the one that you can use. The only way you would be limited in choosing is if they don't upgrade to the 2015 before the end of the year. If they don't upgrade to 2015 before the end of the year, you have to pick the measure set that's called the transition measure set, because that's the only one fully compatible with 2014 technology.
Alrighty. The next question is, are the DIN and CRISP examples of health information exchange?
Yes, if you are fully using it. Although actually I'm gonna defer on that and not give a final answer, because I'm trying to think about how they specifically wrote these measures. If you're uploading to the Health Information Exchange and then you're doing that and then you're passively waiting for your referral source to go out and get that visit summary, I don't think that really counts. To get credit for sending and receiving, I think that they're looking for you directly sending things between providers. But I'm not, I will tell you, as I speak that, I'm not totally comfortable that, you can't use the HIE to provide that exchange capability. The good news is that we talk to the HIEs all the time, and I will likely be talking to them this week still. So I will validate that, and I will send that out with the answer to that question with our follow-up.
Okay, fantastic. To qualify for patient-specific education, must the education resource be provided electronically, or is it sufficient to merely record in the EHR that appropriate resources were provided to the patient?
Okay, so again, think about what we're trying to do here. We're trying to meaningfully use, I know they don't call it that anymore, but we're trying to meaningfully use the technology. So if basically what you're saying is, well, I talk with my patient and I realize they need a pamphlet on diabetes. And so I have a pamphlet on diabetes and I give it to them. And then I document in the record that I gave them a pamphlet on diabetes. You're not using the EHR to identify the educational resource that is needed, nor to provide it. So the idea of this is to use the technology within the EHR to, based on the data that you've entered about your patient, for basically the EHR to recommend to you, these are things that would be appropriate for this patient, and they are available electronically. Now, whether you print that or just hand it to them, that's fine. But it's using the technology to provide the information and identify the need for the information. It's not simply about, I thought they needed education, so I handed them something.
Okay. Can you clarify the meaning of electronic case reporting? I'm
I'm going to refer you to the handout called QPP fact sheet, I believe, that's in the handout. Oh, maybe, look, let me expand handouts and then I'll tell you what it's called. QPPF, ACI fact sheet. I believe that you will find the definitions for those there.
Okay. Can you explain how to do the security risk analyst or get support for that?
Yes. So let me do something here. I'm going to pause my screen a minute and see if I can't pull something up and then show it. Bear with me.
And Cindy, while you're doing that, I just want to remind everyone that I will send out a follow-up later with the recording of today's webinar and Cindy's answered questions to all the questions asked today. So if we don't get to your question during our allotted time, it would definitely be answered in the follow-up email.
So Kalyn, do we see the screen now that says healthit.gov?
Yes.
Okay. So this is a site that fully explains what a security risk assessment is, all right? And it gives you a tool that you could use to self-assess. You want to read the disclaimer. It's provided for informational purposes only. Use of the tool is neither required nor guarantees compliance with laws. Please note that the information presented may not be applicable or appropriate for all healthcare providers. The SRA tool is not intended to be exhaustive or definitive source on safeguarding health information privacy. For more information on these rules, please visit HHS Office for Civil Rights and Health Information. So this is an excellent site to tell you more about what is involved in a security risk assessment. And they even give you a tool that you could technically use to do your own. I just caution that if you do not feel really, really comfortable understanding everything that it puts forward and understanding the requirements, you are much better served to enlist the help of your EHR vendor, the Quinn QIO, someone else who helps to do these. Because if you attest to it and then your documentation can't really support that it was done fully, correctly, accurately, that will mean that you won't pass that audit. And I know that it costs money to do those things. Even that's even the QuinnQIO, that is a billable service that they provide. But a relatively cost-effective way and definitely a high-quality way to do your security risk assessment. We'll put the link for this healthit.gov, the full link, in the questions and answers.
Okay, fantastic. Someone said they only counted 18 improvement activities that are available for bonus under ACI, and also asked if you could talk about the required annexation for ONC surveillance and information blocking.
Okay. 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. So I got 19. So there's that. That's 19. And then the requirement, what was the second question?
The second question is also, can you talk about the required annexations for ONC surveillance and information blocking?
I cannot speak to that. I would need a little more information if you want to give that to me. Are we talking about an ACI, specific ACI measure there, or are we talking about a specific surveillance, in this? No, it's not in there.
It's directly in the final rule that I found 18 measures, they said.
Okay, well, so the 19 measures that we had, the 19 measures that we had have come directly from the CMS guidance on this. So if, I'm not sure which one is here that is not in the final rule. That is, so we'll look into that to make sure to validate 18 versus 19. Do we have any other additional information on, maybe if you unmute, you can just talk to me about it, the ONC?
If this person likes to be unmuted, just go ahead and use your raise hand icon. Also, the ONC and information blocking, this is in the final rule as well. Let me see if they've raised their hand to allow me to unmute them. Not yet. Let me just confirm if they're okay with that real quick. Another question while that person gets back to us, Cindy, is if a primary...
That's okay, and I wrote it down, so I'll investigate. Go on.
Okay. If a primary care practice is part of a system that also includes specialty practices, and if all practices have access to the same patient data, does that count as providing a summary of care to the specialist, or must a specific document be sent for the referral?
I believe that there must be a mechanism by which it is made available. So if it's all on the same EHR, if what we're saying is I'm in a system and we all use Epic, and so my summary of care is there, as long as there's a mechanism for the PCP to know that activity took place, so they even know to look for it, or that it's out there, then it's being electronically provided. I don't know that it would mean that, well, just because we file everything in the same EHR, you can find anything you need in there, so they'll find it. That's not really the intention. The intention is to make sure that that referral source or that consultant that is being referred to knows that information is available.
Okay. Another question, and I'm aware that we've gone over our hour time slot, so of course we understand anyone who can't continue on. But to go ahead and finish up some of these questions, Cindy, if a health system uses a single TIN for many owned practices, could it submit data for the whole system once including only 6 quality measures, or must it submit separately for each owned practice?
If they're billing under the same TIN, that's a group, and they can submit 6 measures as a group for everybody. Nope, even though they're multi-specialties, they could pick 6 measures that cover everyone. It's totally, I mean, if you have the same TIN, if you're billing under the same TIN, you're a group.
Alrighty.
You can be a group.
That's fantastic. Just going through, I think that is all the questions. The only other question that really came up was just a couple people asking how to get a copy of the slide deck, which is in handouts, pane of your task bar, and will be also sent to everyone in the follow-up. Cindy, do you have anything else?
I don't have anything else. I really want to thank everybody for joining us 3 weeks in a row. It's been a great experience and our best attendance ever. And so thank you, and I hope we'll hear back from you again for future webinars.
Yes, and thank you, Cindy, for your time. Appreciate it.
Thanks.
All right. Bye, everyone.